Your body is not waiting for your diagnosis to catch up with it. Right now, while you're waiting for a definitive label, while your rheumatologist, your allergist, whoever wants to watch and see, while your labs are borderline, the biology keeps moving. Damage accumulates, risk compounds, and the system is not telling you this because the system is built around confirmed diagnoses, not around the years it takes to get one. If you've been told your labs don't quite hit all the check boxes to confirm Sjögren's, lupus, rheumatoid arthritis, mast cell activation, this video is for you. 3 things today. What the research shows happens during those waiting years. Why so many of you are being told to wait due to documented misuse of diagnostic criteria that affects 1 in 3 patients. And what the psychology of diagnostic limbo actually does. Why getting any answer, even a hard one, is measurably better for your well-being than staying in uncertainty. Then I'm going to tell you what to do today without waiting. Hi, my name is Dr. Kara Wada. I'm a quadruple board certified allergy, immunology, lifestyle medicine physician. I also live with Sjögren's disease and dysautonomia, and I care for patients living at the intersection of allergies and autoimmunity, many who are living in this limbo. So let's start with how long women actually wait. 2 studies give us the numbers. A 2021 study of 255 patients found an average diagnostic delay of 3.47 years from the first symptoms to a confirmed diagnosis. In this case, we're talking about Sjögren's as our example. And in 2023, a review put it at roughly 6 years. These aren't outliers, they're the norm. This is what patients are telling me when they come to see me at the Immune Confident Institute. And here's what's happening during those years. Sjögren's carries an elevated risk of a specific, usually slow-growing lymphoma called MALT lymphoma. The correct way to hold this number, if you follow 100 people with Sjögren's over their lifetime, 5 to 10 of those 100 will develop it. That means 90 to 95 will be totally fine. Over 10 years, the most recent prospective data puts the figure at roughly to 3 to 4 out of 100. And if you don't have specific high-risk markers, things like cryoglobulins, low complement, and large lymph nodes, you thankfully are at the lower end of that range. Why this matters for diagnostic delay. Lymphoma development in Sjögren's is a stepwise, time-dependent process. It builds over years of unmonitored inflammation. The predictors appear years before the lymphoma itself. First, often you'll see an elevated rheumatoid factor. Then you might see a positive cryoglobulinemia test, might see salivary gland enlargement, lymph nodes that don't seem to go down. This is a process that can be tracked and can be interrupted, but only if someone is watching. So every year of diagnostic delay is a year that no one is keeping your eye out for these changes. Next, I'm going to talk about cardiovascular and nerve risk quickly because I want to spend a little more time on folks who are seronegative, what I call the seronegative trap. A 2025 Danish cohort study of nearly 5,000 Sjögren's patients found significantly elevated risk of heart attack, stroke, blood clots, and peripheral artery disease. There were hazard ratios between 1.2 and 1.6. These are real differences, and the risk appears time-dependent. Some risks peak early, others a decade after disease duration. The window for catching them varies. When it comes to peripheral neuropathy, about 15% of Sjögren's patients will develop nerve damage, and the studies consistently show that these patients have significantly longer disease duration. Neuropathic symptoms precede diagnosis at a 2-to-1 ratio, meaning nerve damage is already starting before many patients are diagnosed. An honest caveat and why this matters. Most of this data is observational data, not randomized trials. We don't yet have proof that diagnosing you 2 years earlier would change your outcome. What a 15-year longitudinal study does is this. Disease activity decreases over time, but damage keeps accumulating regardless. And one of the most consistent predictors of damage accrual was the absence of hydroxychloroquine therapy, which you can only start once someone is treating you. So let's shift gears into those who have normal labs, the seronegative trap. Here's what I want most newly diagnosed or not yet diagnosed patients to understand. Approximately 1 in 3 biopsy-confirmed Sjögren's patients do not have anti-SSA antibodies. They are seronegative, meaning their blood work is normal. And many of them are being told to wait, not because they don't have the disease, but because the tool being used to rule it out was never designed as a diagnostic tool. In 2016, the American College of Rheumatology and EULAR, which is the European body, published classification criteria for Sjögren's disease. These were explicitly built for research, for enrolling patients into clinical trials consistently. They are not diagnostic criteria. The original paper says this, and yet in clinical practice, many rheumatologists are applying them as the final word. If you score below the threshold, sorry, you don't have Sjögren's yet. The research has documented this problem directly. In 2021, a study found that 15.5% of seronegative patients diagnosed by expert rheumatologists fall completely outside the ACR EULAR classification criteria. They have the disease. They don't meet the classification criteria. So, if you have a clinician who does not understand the distinction, they are almost always told to wait. For seronegative patients, the diagnostic path forward often is a minor salivary gland biopsy, a small outpatient procedure done in the lip that looks for a specific pattern of immune cell infiltration. Call it a focus score. Low risk, generally, high information, though approximately 20% of salivary gland biopsies will be false negative. For antibody negative patients, this is the gold standard and the next option when it comes to diagnostic tools. One tool that's relatively new and less invasive is an ultrasound of the salivary glands. This can look for particular patterns in inflammation, and increasingly rheumatologists and immunologists like myself are getting trained in this modality. The problem, though, often is the referral sequence. Many patients who have normal antibody tests are simply not offered a biopsy or offered an ultrasound. They're told to come back in 6 to 12 months, if that, and the biopsy or the ultrasound never come up in conversation. But the reality is your symptom burden, fatigue, pain, dryness, that's all still there, right? We still feel just as wrecked. And we're still accumulating the ongoing damage of that unchecked inflammation while we wait. The question you can ask your care team by name is, has a minor salivary gland biopsy or ultrasound been considered? And could that be a next step for me? Most patients never ask for it by name, in part because they may not know, it doesn't come up. And that one question can change the direction of your care. I want to talk about what the waiting actually does to you, not as a metaphor, but as a documented psychological phenomenon. There's a landmark study in medicine on Huntington's disease. It's a devastating disease. It's a fatal, progressive neurologic condition, and there's no cure. It's genetic. For years, researchers assumed that people told definitively that they carried the gene would have worse psychological outcomes than those still living with uncertainty. The reality is they were wrong. At 12 months, both those who were gene positive and gene negative groups had better mental health than those who remained unresolved. The certainty of a hard diagnosis was better than the open question. This generalizes, but a study of 838 patients going through cancer diagnostic workups found that anxiety ran at 30 to 35% throughout the pre-diagnostic period, regardless of eventual diagnosis. After the diagnosis was established, anxiety improved across the board, even in those who received a cancer diagnosis. Diagnostic uncertainty is its own injury. And when your brain can't make sense of what's happening to your body, it does something predictable. It manufactures agency wherever it can. You research, you try protocols, you cycle through supplements, you book the 7th specialist appointment, you end up in Reddit or Facebook forums at 2 a.m. And this isn't irrational. This is a documented response to a loss of control. It's what psychologists call compensatory control behavior. In a 2025 survey, about 83.8% of Sjögren's patients had used complementary or alternative medicine in the preceding year. I'm one of them. 2/3 were self-administering supplements and vitamins. These people aren't making bad decisions. These are people trying to do something in the absence of medical guidance. And here's the piece I want you to hold on to. A 2025 study of nearly 2,000 autoimmune patients found that those who had received a psychosomatic misdiagnosis before their correct diagnosis, i.e., it's just anxiety, it's just stress, had significantly worse mental health outcomes years later. Higher rates of depression, lower self-worth, and they were significantly more likely to go underreport symptoms to future physicians because they had learned that reporting symptoms accurately led to being dismissed. That underreporting is downstream of the weight. That is what the weight costs you, not just biologically, but in your relationship with the medical system going forward. I'm not saying every doctor who told you to wait was wrong. Diagnostic uncertainty in autoimmune disease is real, but what I am saying is the weight is not neutral. It has a cost, and knowing that makes it worth pushing harder for a resolution. So 2 things you can do today. Step 1, at your next rheumatology immunology appointment, ask this. I've read that minor salivary gland biopsy or ultrasound are diagnostic gold standards or next steps for seronegative Sjögren's patients. Given that my antibodies are negative or borderline, has a biopsy or ultrasound been considered as the next step? You don't need to be combative. You don't need to, name the specific test. Most patients never do, but you can put it on the table. Start the conversation. Step 2, start these 4 interventions now. The evidence behind each is different in quality. I'll be straight with you about that. So we'll go through from strongest evidence downward. Dental protection, prescription strength fluoride toothpaste, and dental appointments every 3 instead of 6 months are guidelines supported for Sjögren's. So you can ask your dentist if you can schedule those appointments more frequently. They may be able to give you a cash price if your insurance will not cover those increased frequency of visits, which sometimes can be less than a typical billed insurance rate. Something that's reasonable to try, omega-3 supplements for dry eye. The evidence is generally conflicting. The largest trial showed no benefit. Shorter trials showed some benefit. Relatively low risk. It also may have some benefit for general inflammation, joint pain kind of symptoms as well. This is worth discussing with your ophthalmologist and or your primary care physician. Some of the things that I would worry about if you're already on blood thinners, omega-3s, especially at higher doses, can cause more bleeding, easier bruising. So those are things that you should discuss with your personal healthcare team. Remember, this is educational. I am a doctor. I'm not your doctor in this specific instance. Observational only. So vitamin D deficiency is more common in Sjögren's patients and correlates with worse symptoms. So they go together. We don't know if they're linked. There hasn't been any interventional trial, but correcting a deficiency is good general practice. So that is something to consider. You could ask to have your vitamin D level checked and or start low level replacement. And finally, sleep and stress regulation. Not because thinking positive helps, although positive psychology would say that it does, as long as we're not venturing into the toxic aspects of it. But mast cell activation, immune system activation is directly triggered by stress neuropeptides. Staying on a consistent sleep schedule and building your toolbox of ways to help manage the stress of everyday life in an increasingly burning world with a chronic disease that is not well understood in a healthcare system that is a dumpster fire, it's not a bad idea. And it actually is a helpful tool from the biological standpoint. If you can turn down your body's, excess stress response, get more into that rest and digest mode, it does help your immune system with regulation. None of these things require a confirmed diagnosis. The weight has a biological cost. Lymphoma, cardiovascular, and nerve risk all correlate with disease duration. Damage can accrue even when disease activity looks quiet on paper. 1 in 3 confirmed Sjögren's patients are seronegative. Some data would say up to 40% of patients with Sjögren's are seronegative, and many are being told to wait due to documented misapplication of research criteria. The question to ask is about biopsy or ultrasound, and diagnostic limbo is its own injury. The doctor hopping, the 2 a.m. research spirals, the cabinet full of supplements that may or may not have good data or safety information behind them. They're all predictable responses to uncertainty, and the research shows that a confirmed diagnosis, even a hard one, is better for you than staying in that uncertainty. You are not being impatient. You are correctly identifying that every year of inaction has a cost. Here's what I want you to know. and I do my best to read every single comment. How long did it take you to get your Sjögren's diagnosis? Or are you still working on it? What were you told during that time? Drop it below, because your answer matters for every person who finds this video next and needs to know they're not alone. While you're here, 2 things. The Immune Confident Indicator quiz is in the description. It takes about 4 minutes. It gives you a starting picture of where your immune load, metabolic strain, and heart terrain actually sit right now. And this month, April of 2026, if you want to take a look at 81 biomarkers, we have a lab panel we've put together, clinical expert review, written 12-month plans specific to your terrain. That is the Immune Confident Blueprint Checkup. It's not a medical visit. It is a roadmap to help bring to your existing care team. And for those who sign up this month, you will get a free seat in our Live Foundations program pilot. Everything is in the description below. If you are a current Immune Confident Institute patient, don't purchase that. Message us terrain. We have you taken care of. And remember, this video, as all, are for medical education purposes only. It does not constitute medical advice. Sjögren's disease is a complex condition, complex disease requiring evaluation by a qualified care team, ideally an immunologist, a rheumatologist, a neurologist who's well-versed in its complexity. Self-diagnosis or self-treatment should not be based on this information alone. Always consult with your healthcare professional and team before starting any new treatment, supplement, or medication. Until next time, be well.